This week on the BackTable podcast.
It's very interesting. When you use lipiodol, you inject the lipiodol. You see the lipiodol stays where you inject. It's not going to expand everywhere. The first time you do that, you are scared. You think that maybe my treatment stays there, but actually it doesn't matter where you inject. What we recommend is to go to the center of the lesion if you want to make sure that it distributes everywhere.
Welcome to the BackTable podcast, your source for all things endovascular or otherwise minimally invasive. You can find all previous episodes of the podcast on iTunes, Spotify, or backtable.com. Subscribe to the podcast, leave us a review, or reach out to us on Twitter or email to let us know how we can make this a more valuable resource for the endovascular community. This is Michael Barazza as your host today, and I'm honored to welcome Dr. Jafar Golzarian to the podcast to talk with us today on the Intra-Arterial and Percutaneous Treatment of giant hepatic hemangiomas. Dr. Golzarian, thank you for joining us, or I should say coming back.
Hi, Mike. It's a pleasure and honor to be back. I enjoyed really very much the first podcast we had together, and I'm looking forward to this.
Yeah, the first one was a good one. We talked about genicular artery embolization, and that was a really popular one we got a lot of good feedback from, and it's actually one that I used a lot in my own practice and starting to introduce that. Before we get started, a lot of our listeners are students and trainees, and you guys have a really strong IR program at University of Minnesota. And I was hoping you could begin by telling our listeners, a little bit about the program and what the training is like there.
Yeah, as you know, University of Minnesota, way before me, was one of the two main centers of training in IR. Kurt Amplatz was from here. So I am actually feeling big shoes, because I am I have the endowed Amplatz chair. So it was the place where Amplatz and Castaneda and Dave Hunter lived and worked and, educated the whole generation of IR. And we're lucky we have a very good group of different level of training, the young with a lot of excitement and more senior like me with maybe less excitement, but some experience. But altogether, we have really a very comprehensive program. We cover almost everything in IR. And we have 2 IR residents every year and some spots for ESIR training. And so it's very, very competitive, but really a good program. People are very nice, try to understand the dynamics of, new trainings and the needs of fellows. And Minnesota, nice. This is one of the strengths of this program. I think it's a great program. We have really great group of faculty and amazing candidates.
Yeah, and just from following the literature and the educational opportunities you and your colleagues have put out, it seems like in addition to kind of the bread and butter IR, you guys are doing a lot of more cutting edge interventions in our specialty.
That's true. We being involved with GEST and other major meetings, we have been really very interested and in contact with new developments, especially in embolotherapy. And we were lucky that people in our team are interested to, look into some new techniques. And we have had a lot of FDA approved IDE on almost every new technique that is coming out. And hopefully we can continue to add some value. It's really a pleasure to work with the group of physicians we have here, and we have amazing techs and nurses as well. It's really a good group of PAs. It's really good, fun department.
You actually answered something that I've been struggling with for a long time. I have never really known if it was GEST or GEST. And so,
yeah, it's good. Yeah, you're right. It's global. You're right. Most Europeans call it GEST, but it's a good question. It's GEST, Global Embolization Symposium and Therapy.
Tell us just a little bit about GEST.
So, Mark Sapoval, myself, and Ziv Haskell, we started GEST in 2007. That was at the time where the hottest thing in embolization was fibroid. And 10 15 years later, we went from like a program where we had 11 sponsors to a program where 32, 33 sponsors are coming. We had barely a glue and onyx. Now this year, as you have seen, probably We have 7, 8 different companies coming with different liquids. We had only one platter at that time as a plug. Now we have like, I don't know how many plugs, 7, 8, 9. At the time, it was a challenge to start this, and there was not enough support from industry, but boy, support from participants and IR was so overwhelming. And we are very lucky because the program stays really very popular, and we have a scientific committee and course directors. Gary Siskin is amazing, and the amount of work he puts in this. Jim Spies, Cameron Arar, he's with Lewandowski. They are both working very hard on the oncology program. And then we have, of course, Dr. Sone from Japan and Dr. Gert Malo. These are the course directors. And then we have a lot of good friends from IR across the world. So it became a very popular meeting. Mostly, one of the areas that is really interesting at GEST is the master classes, where we demonstrate different materials coming to the market and materials that are available. What are the technical tips and tricks? And that has been really a highlight of the meeting.
The educational content that's come from it has been superb. I really got a lot of value out of it.
Thank you.
The different sessions and the other stuff you had on prostatic artery embolization. I actually learned a lot of it from GEST.
Thank you. We can't do it without participants and support of you guys. Same thing. I tell you, I've learned so much from BackTable podcast. We are so complementary to things that everybody try to bring on the table. And it has been a good experience. And we continue, we do a lot of guest summits now, which are webinars that are very popular. And because they are free and they are offered internationally, we have very often over 1,000 participants coming just to a Saturday webinar. I was making a joke at one of these webinars was that a Saturday in December during the World Cup, Soccer World Cup. And I say, guys, what the heck are you doing here? You should be watching World Cup finals. But no, we are very blessed with that. And then we have also, as you know, now a GEST MSK. This is 2-3 days now every year in Paris. We did the first one in 2023, January. The next one would be in January 24, still in Paris. That has been also very well received by IR across the board. So
that sounds great. Let's talk about hemangiomas. How and when did you start treating these?
So, like all of us, we have been treating this for years and very frustrated because you go and you embolize, you do the chemoembol the way you always do, and it's barely changing, or you get some infarct, and then patient symptoms come back. I remember one of the hardest patients we had, I had to go after embolization, I had to go to every hepatic vein, put a catheter there for the surgeon to know when they go to operate, to know where they have to stop, because that's not an easy surgery. So in 2015 or 16, a friend of mine from Tehran, from Iran, Dr. Akhlaghpoor, sent me a paper with his results of intra-arterial taste by using bleomycin-lipiodol. And I watched that. I was so amazed, surprised. And so I helped look at the cases, edit the paper, and just published at CVIR. Then we looked at the literature. Actually, this was started in China, the intra-arterial treatment of those hemangiomas with bleomycin. And there is, believe it or not, Michael, there are probably 2,000 cases already reported for that. And the result was very good, very interesting. And then while I was doing that, another friend of mine who actually came to Iowa when I was in Iowa for 3 months to observe, he's at the University of Tehran. He was thinking that there was a paper in CVIR, I think it was in 2018, talking that giant hemangiomas are not hemangiomas. They are low-grade malformation, venous malformation. So he thought that, how do I treat the venous malformation? I inject bleomycin. Let me try to do that. But instead of doing intra-arterial, he decided to inject percutaneously. And they did 5 cases, was published in JVIR, and then they continued. They published this in radiology. And I look at their data. It was amazing. So I talked to them, worked with them, and then I started to do some here at the university. And we were amazed to see how it works. One of those things that you look at it and you say, boy, these guys have changed the course of a disease by doing these techniques.
So that actually makes a lot of sense for people who are treating vascular and lymphatic malformations. I mean, direct injection of bleomycin is one of the mainstays of that therapy. Of course, it makes perfect sense it would work for these.
Absolutely. And you know what is sometimes difficult for us in Western countries is that a lot of those papers, when they come to the journal, they don't get a lot of attention just because, you don't know the authors, even though a lot of journals, they do a blind review. But then also the English writing is not perfect. So I think the fact that I was involved with the writing of that, and then when it was published at CVIR, they asked Tiago Bilim and Otto and myself to write an editorial on that. And the editorial was also very well received. And after that, really, when you look back, I think there is a time before those papers. Yeah, these papers were published in China a lot, the Intra-Arterial. But it had to come to the Western media before suddenly things become more popularized.
Okay. So we see hemangiomas in the liver all the time, and we blow them off and we don't do anything with them. Which are the ones that need treatment?
Great question, Michael. Usually, I would say two types of hemangiomas that need treatment. One that is causing pain. Those hemangiomas need to be treated, and usually they are larger ones. And then some of them also may be responsible of compression of structures such as portal vein or other vascular structure, or even bile duct. So those are, I would say, the major patients that need treatment. There have been some cases of bleeding on those type of things, but that's not really the major indications.
So it's not like an angiomyolipoma when it gets above, say 4 centimeters, you plan to treat it above a certain size, that the risk of rupture is just not quite the same. It's more symptomatic and due to compression, as you said, and secondary effects related to the mass.
Absolutely. It's sometimes also, I have to tell, they are not symptomatic, but patients feel that really a huge mass is there. They don't have pain, but it affects there are some sort of symptoms. It affects their life in a way they can lay, on their right side, or, they can do a lot of sports. And so I would say those kind of lesions also need to be treated.
Yeah, it's like bulk symptoms from fibroids. It's not
exactly.
It's not dangerous in and of itself, but I mean, we've all had fibroid patients who may not necessarily have the standard bulk symptoms, but like, I feel a mass, and that, there's a psychological effect there. And
absolutely, yes.
Okay. So the other issue with hemangiomas that I've seen is that when they get above a certain size, they don't necessarily look like hemangiomas. They just look like big liver masses. And so I'm curious, what's the level of confidence that you need from an imaging standpoint to proceed with treating one of these?
Yeah, that's a good question. Very often, these are younger patients. Most of our patients have been women that have this lesion. They think that you have to, when they are larger, there are still a lot of specific, diagnostic with MR, where MR can really distinguish that. When you look at the MR aspect and also the patient profile, usually it's easier to make the diagnostic of giant hemangioma. There have been some cases where the treatment, the diagnostic is complex, but thanks God we didn't have that so far.
Right. Okay. Well, you began to answer my next question in the patient profile. The ones that you're treating, is there a certain age range?
Yeah, most of them I would say are patients between 30 to 50 years old. Most of them are women, but you can see it in younger patient and older patient. Depends on how long they have been really living with that. Because when you look at the surgical alternative, there's such a big difference that some of those patients really, rightly so, didn't want to touch it.
Yeah. Now, I'm not quite as familiar with the natural history of these. So let's say you've got a patient with a fairly large hemangioma, but the symptoms are, they're manageable. Will these ever regress on their own, or is this something that's going to persist and perhaps grow?
There have been some cases that show that hemangiomas can regress, but the majority, they just or stay stable or they keep growing. And when they grow and become symptomatic, it becomes very often so bothersome that even a complex surgery, they finally say, you know what, we are sick of it. Something has to happen. But in general, a lot of them stay stable, they don't change in size. So those that are actually growing and causing symptoms are the ones that you need to pay attention to.
Now, the patients that are referred to you for management of these, where are they coming from? Is this, the hepatobiliary surgeons, the hepatologists?
Yeah, right now we had to talk about that with our surgeons locally, and most of the times our hepatobiliary surgeon and a few patients that have seen our papers or have through an interventional radiologist have heard about this, and I have had patients contacting us from New York, from other states, and sometimes I tell them, guys, you don't need to come to Minneapolis for that. That's easy. Just tell me where you want to go, and I will call the IR team there, and they can do it. It's really an easy technique. But most of the patients are or self-referred or from the hepatobiliary surgeons.
You say it's an easy technique, but it's a technique that I don't think is in widespread use. Not a lot of people are familiar with your treatment algorithm. In fact, you see on SIR Connect probably once a year, someone will post a case asking for help treating a hemangioma. And, we'll be talking about people that are ablating them, doing routine, conventional or DEB-TACE. And hopefully this can help get the word out of an effective treatment option. Now, are there other treatment options aside from surgery and percutaneous and intra-arterial therapy? Are there any systemic therapies that have shown any efficacy in treating these?
Yeah, some systemic therapy have been described and have been used. I don't know exactly the percentage of success with those. It still remains a treatment that I really think that with the result we have with percutaneous or intravascular, the improvement is so overwhelming that I really don't think anything else should be done. Of course, I also have seen, as you say, ablation. Some patients have been treated by cryoablation. Some have been treated by ablation by microwave, and depend on the size. But when you look at those 14, 15 centimeter lesions, I think nothing can compete this intravascular or mostly percutaneous technique.
So do you see these patients in clinic first?
Yes.
Okay.
I see them in clinic. I talk to them about the risk and benefits. And sometimes I inform them that we may need to do more than once injection. And they just ask, doctor, when? Because they just want to go and do it as soon as possible.
Well, it's an interesting concept for treating a lesion like this that is, one, usually not inherently dangerous. There's not a big risk of rupture, but two, it's not a cosmetic issue. When I look at the vascular and lymphatic malformation patients I'm treating, it's primarily cosmetic and sometimes the ones that are in the head and neck area can be some other risks associated with that. But for a lesion like this in the liver, where we're mainly treating the symptoms, how do you establish the goals of your treatment? What are you hoping to achieve? And how do you know when you've gotten enough?
It's a very good question. So one thing is very important to the physicians that are doing that. You need to explain to the patient that the tumor will take some time to shrink. So what I have seen, even in my group, is that a lot of physicians, they look at the result at 1 month and they don't do a measurement of the volume, but they look at the largest diameter and say, there has been not much changes. So they are excited, bring the patient back and do another one. And I would say 95% of those patients don't need a second injection. Unless I had a case where I couldn't, when I was injecting, majority of my contrast when I was checking was going directly to a hepatic vein. So I didn't inject the amount of dose I needed. So those patients, you may have to bring them. But if you give the right dose and just need to be patient, you need to tell to your patient that it may take up to 6 months where we can start to see a significant change in the size. The symptoms, very often, they improve within the first months and the patients see the difference, but the volume will change with time. So really the goal of this treatment is to remove the symptoms and the risk of compressions of organs. So sometimes if the compression and the bulk symptom is the problem, you may want to bring the patient back and do another dose within the next month or two, just because if there is some symptomatic compression. But other than that, I would say do one treatment, let the patient relax, see the patient with imaging. I always see the patient at 1 month, 3 months, and 6 months, but the imaging that matters for me is at 6 months. Most of these patients, they want to look at their MRI at 1 month and 3 months to see the shrinkage. At the beginning, I was doing that also for all patients because it's very amazing to see the difference in the volume. But yeah, wait 6 months. The expectation is that by 6 months, you will see a significant change in the volume and resolution of the symptom.
Wow. Let's talk about treatment planning. Do you do both intra-arterial and direct injection for all of the lesions, or is it a combination? Is it different for each patient?
Well, if the access percutaneously is easy, which most of them are, I would prefer to do percutaneous injection now. And I could never believe that one day I would prefer percutaneous over intravascular. So that's the first thing. The only thing that I would say is that a lot of insurances, they don't. So there is a way to ask, and I think you need to talk about the sclerotherapy of liver hemangioma, I think, to get a good approval. But if they don't approve it for percutaneous, you just do a chemoembolization, and that is approved. So if we do chemoembolization by bleomycin, is when the insurance rejects the percutaneous approach for reimbursement. So, but I would say if you have a symptomatic lesion that is difficult to reach, or you need to do CT guided, or you can do intravascular. But most of the patients right now we do are percutaneous.
So for the percutaneous lesion, the percutaneous treatments, are you doing most of them with ultrasound or CT guidance?
Most of them with ultrasound, but even sometimes you see that the size is big. Sometimes with the ultrasound it's difficult to evaluate where you want to inject. And so I recently talked to Dr. Rukni, who actually invented the technique. Yeah, he's moving more and more towards CT guided for those patients. So I just think that it's much easier to position the needle. Majority of our patients are still ultrasound guided.
Okay. Are you doing this under local anesthesia, moderate sedation, or general anesthesia?
I would say you don't even need moderate sedation, but as you know, in the US, most patients prefer moderate sedation, but you can definitely do it with local anesthesia.
So another question regarding treatment planning. I know that when I'm treating vascular lymphatic malformations, I have to order the bleomycin dosage before the treatment. How are you determining what dose to use for each lesion?
That's a very good question too. So I actually looked at what those other groups have done. They have started to do 30, 45, and 60 units of bleomycin. But it seems more and more that when you are dealing with the larger than 10 centimeter hemangioma, it's better to go directly to 60 units. And so for me, the majority of my patients are larger, and I go directly to 60 units. And you can, very often, that's the only thing you need to do. You don't need to bring the patient back and do another one, but you can still do more if you need to.
And so when you're treating these large lesions and they start to look more heterogeneous the larger they get, and they have different components on imaging, where are you targeting needle placement and injection? Is it one spot, or are you targeting several areas? Is it important to hit the periphery? Where are you putting the bleomycin?
At the beginning, we thought that we go and puncture to the center, and then we reposition the needle and go somewhere else. And especially when you use lipiodol, it's very interesting. When you use lipiodol, you inject the lipiodol. You see the lipiodol stays where you inject. It's not going to expand everywhere. The first time you do that, you are scared. You think that maybe my treatment stays there, but actually, it actually doesn't matter where you inject. What we recommend is to go to the center of the lesion if you want to make sure that it distributes everywhere. And by the way, the knee groups in the University of Tehran, they don't inject the lipiodol anymore. They just directly puncture a 22 gauge needle into the center. They do an injection to see if there is no major portal vein or hepatic vein opacification. And then they inject the bleomycin, and they are done. That's as easy as it is. Yeah.
So do you recommend injecting contrast through your needle?
Absolutely. So you start with the injection of the contrast.
With the 22 gauge needle?
Yeah. You can inject slowly. And the goal really is to see if you are in the portal vein or a bile duct or something. Sometimes that can happen. And actually, even if you start to inject and you modify your position and you start to see that there is still some calcification hepatic vein, you can still go ahead and treat. The majority of that bleomycin will stay in the tumor. And if some goes systemic, the dose is not huge to cause any significant problem.
So you typically do one needle and you go to the center, inject contrast, and then do your treatment.
Yes.
So for your treatment, what are you mixing the bleomycin with?
So you just take the same amount of. So if you want to use lipiodol, you take 10 cc of lipiodol and 10 cc of diluted bleomycin or distilled water or saline. And so you have a syringe of 20 cc that you mix it and then you inject it. Or what I do right now is just a 10 cc solution of bleomycin into a 10 cc syringe. And that's all that I use.
Great. Does it come diluted or do you have to add the water?
I asked to send it diluted to 10 cc.
Okay.
Yeah.
That's what I'm doing as well is having them prepared for me. Not for this. Okay.
For your peripheral cases.
Yeah. Okay. So, you've done the injection, remove the needle, and then they just stay for a few hours and go home?
Yes.
Do they experience anything like a post-embolization syndrome? I realize this isn't a traditional embolization, but I'm curious if they get any symptoms usually after the treatment.
The literature report was talking about some abdominal pain. That abdominal pain sometimes can be minor abdominal pain, and a lot of patients may feel that. So we explain to the patient that you may have abdominal pain and we give them painkiller. The other thing that they may have is about 14% of the patients that have been reported to have nausea. And most of those patients is just few hours and they just do well. Some brand of bleomycin may cause hyperpigmentation. You may have seen that also in peripheral embolization, so in venous malformation. And that's also not significant, but when you compare it to the scheme of the disease, the importance of the disease is not a huge problem, but hyperpigmentation can happen. The other thing also, as you know, you need to always go through a normal liver when you get to the hemangioma, because the risk of bleeding, if you go directly to the hemangioma, is higher than other lesions. So there has been 2 cases of bleeding, perihepatic bleeding, because of the fact that they directly puncture the hemangioma.
So let's talk then about the smaller percentage of patients in whom you're doing an intra-arterial therapy. How is it different from a routine chemoembolization for HCC?
It's not that different. The only difference is that you don't necessarily want to go super selective in this one, because the huge city, the arteries are, you have, when you do a very large HCC, how it looks like. You just go and inject it into the artery. In the intra-arterial, I usually mix it with lipiodol, the same mixture that I explained, and you just give the whole dose, and in a non-selective manner. So I don't give low bar unless you have to do low bar, but sometimes, let's say you have a segment 2 and 3 large hemangioma, but segment 4, you can save it. So you just go to those area. But if you go even the whole left lobe is fine, as long as you make sure that you don't have those smaller collateral that goes outside the liver, which is not a huge deal.
Is there much of an embolic effect of the bleomycin mixture when you're injecting these hemangiomas? I mean, they don't really act much like a hepatocellular carcinoma, in terms of the angiogram. I'm curious what the actual embolization is like.
Yeah, you're right. The bleomycin doesn't have an embolic effect, but lipiodol has some. So in intravascular, we will use that. And by the way, there are studies that showed the usage of intravascular bleomycin. They don't necessarily recommend to do embolization after that. So you just inject the solution, you get out. Now, some people, they do still some particle embolization. And one of my partners actually has done that and had good result. But I think those papers don't report the need of doing an extra particle embolization.
Okay. Now, when you're doing the intra-arterial treatment, you're not using particles. Do they get much post-embolization syndrome?
Yeah, the same. A little more than the direct puncture. They get some post-embolization syndrome within the next 3 days, but most of them very well tolerated very well. It's not as bad as the CTASE patients.
Right. So these are large tumors, and as you said, it's not infrequent to have to perform more than one treatment on these patients. How and when do you decide if a patient is going to need another treatment? And how do you time that relative to the initial therapy?
When the patient symptoms don't improve significantly, or when you see that the shrinkage is not to your liking, because it is actually shrinking significantly when you use that. And that happens, as I mentioned, when you don't use the right dose, when you inject like 30 units in a very large hemangioma, those patients, you need to bring them back. So as I mentioned, one of my patients recently had a position where when I was injecting, I thought that the majority of solution was going to the hepatic vein. So I reduced the dose, and so I will bring this patient back because the patient's symptoms improvement was not as expected. Usually the symptoms go away. They are the happiest patient ever after that. So if you see that the patients are, sometimes the patient don't know the expectation. They really need to have no symptoms anymore.
So do you get your first imaging at 3 months or 6 months after the treatment?
To be honest, I take them at 1 month, and then when the patient can afford it, I would take it as 3 months and 6 months because of my curiosity of trying to see and measure and have those showed in images in conferences and everything. But I tell them that it's their choice. The real imaging that matters is 6 months, especially if you see the patient symptomatically getting better. If the patient at 1 month say, I don't have a very significant improvement, I would do an imaging at 3 months, and then we decide if we need to do more or we are satisfied, and then we just continue follow-up.
So what happens after 6 months? Do they continue to regress, or do you find yourself having to treat them a year or two later?
No, not only our patient, but also I checked with the other groups. None of these patients come back for new treatment.
Wow.
So
that's fantastic.
Maybe in 20 years they will have a new hemangiomas, and then you would have to treat them. But one of my patients actually is a patient we treated in 2014 where the patient had to have a surgery. And 9 years later came back with new, the problem is that there is also like other lesion, the margin, you can't clear the margin 100% when you do surgery. So those hemangiomas may come back. And so that's something that actually is a little more harder to treat, but at least from those that have been treated and we have treated, none of them come back.
That's fantastic. This sounds like a very gratifying procedure because, as you know, a lot of the work that we do in the liver for tumors, these are patients that we don't often cure. We see them and, we keep treating them and then eventually the disease often wins, HCC or metastases. And it's a really great opportunity anytime we get to treat somebody like this where, we can treat them and that's it. It's like an angiomyolipoma or a renal cell or a fibroid, and it's always really gratifying to be able to treat some patients for pain. It's one of my favorite things that we do.
Absolutely.
This sounds like a fantastic treatment option. I look forward to bringing this up to my own hepatobiliary surgeons. That's really about all I have. Is there anything else about this or anything else that you wanted to cover that I didn't get to?
One thing that sometimes this patient at very high dose, they may get pulmonary fibrosis, but not at the dose we are using. And then there has been a case of liver abscess reported, and some of them may have allergic reaction to some brand of bleomycin. But in general, it's very well tolerated. The only thing else I would say is really it's important to discuss to the surgeon, because the surgeons who are actually strong surgeon who actually decide to go and treat those hemangiomas, they know how difficult it is to treat that. And the post-surgical complications are so bothersome, as you know, from bile leak and whatever you can imagine. And removing a liver, the part of the liver is not an easy surgery anyways. So I think it is very important and I have some slides I can share with you. I'm sure there are others online. I think you can go to GEST or other meetings. You can find the slides. Show them the difference between before the treatment and at 6 months, the shrinkage. Some of them actually disappeared almost totally. So it's important when they see that and everything it takes you is a 10-minute procedure. I think they will be your biggest supporter.
Oh, yeah. And relatively speaking, it's a low-risk procedure.
Absolutely. It's such a, as you say, it's a very gratifying procedure. It's some of those that you really enjoy doing it. When you do fibroid, it's the same because most of our fibroid patient symptoms disappear, but they have some alternative. For this one, there's really no other alternatives.
Fantastic. Well, Dr. Golzarian, thank you for sharing your time and your expertise with us. And I look forward to having you back.
Thank you so much, Michael. I really enjoy what you guys are doing. Congrats, really. BackTable became an educational platform that everybody uses and at any level. And I tell you, each time I have a few minutes, I come and listen to some of your podcasts. Great work. And again, congratulations for what you have done.
Well, thank you.
In a short period of time.
We're nothing without supporters and experts like you to share their expertise. And so we're grateful.
Thank you. My pleasure.
All right.
Good seeing you guys. Thanks.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Don,
Michael Barazza,
Jacob Fleming,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar. Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.